I'm going to talk to you a little bit about St. Catherine's, the organization that that I work for. The programs that we operate, the supportive housing programs for high-cost adults that are experiencing homelessness in Albany and Rensselaer County, and I'm going to talk to you a little bit about our contract negotiations with managed care organizations and a little bit with the PPSs in our area. St. Catherine's Center for Children is based out of Albany. It serves 20-plus counties across the state. It's a nonprofit organization, no religious affiliation. All funding is grant or public funding. We have been around since the late 1800s and offer a comprehensive range of human services. Mostly, it was started as a home for children in the late 1800s. We offer residential services for children ages 5 to 13, including day treatment and special education services. We've operated a 24-bed family homeless shelter in Albany County since the 1980s, where each family has an individual unit. There's a case management team, supported employment. We practice evidence-based practices, which I'll talk about as we discuss a couple of our programs. From that program, like I said, was started in the 1980s. From that program, we began to implement supportive housing programs within the last 5 to 10 years, including permanent HUD-funded permanent supportive housing for adults and families in Albany and Columbia Greene counties. And then I'll work backwards here a little bit, but Project Connect is a SAMHSA-funded street outreach and case management program for adults with high vulnerability. We specifically target in that it's a program for adults with mental health and substance abuse. And we specifically target a population with high vulnerability, disconnected from services. So for example, if someone gives us a referral, we kind of try to do some legwork to check the homeless history of this individual, as well as some of the conditions that are leading to homelessness. And if an individual seems to be connected and leading towards housing, it's not an individual that we could serve, because we really try to identify those that are high cost, those that are disconnected, those that are difficult to engage. So that's a population that we're looking to serve. Project Connect was started because we were serving a high-cost Medicaid population through Project Host. And Project Host started in 2015, and it was part of the New York State Department of Health Medicaid Redesign Team Supportive Housing Initiative, right? Supportive Housing Health Home Pilot Program, right? And so there was a bunch of supportive housing units that were part of the Health Home Initiative, right? So all of these individuals that we identify here, a couple requirements for Project Host supportive housing. You have to be health home eligible, Medicaid eligible, and you have to be a high-cost Medicaid user. Now, the definition of high-cost Medicaid user can be different with different organizations. There wasn't really, at the time, as a pilot program, there wasn't really a definition of what high cost is, and like has been identified today, like who measures this high cost and how do I get that information? Well, we couldn't, so what we did is we started to work with local hospitals, police departments, fire departments, and we just tried to identify those that were, right, like people have different terms for it, but like super utilizers, right? So we have like case studies of people who were, we have our handful of clients who are 50, 100 ER visits over a year. And these were the individuals we attempted to target, right? Because we knew, and that we're homeless. Obviously, it's a homeless supportive housing program. And so through the integration of housing and healthcare, we look to lower Medicaid costs. So housing first, critical time intervention, right? Implementing these evidence-based strategies to help lower costs. So we went into it without having a real background in serving homeless adults, and this program's in Albany and Rensselaer counties, so the downtowns of like Albany and Troy. So we went into it without really having like a huge background in the adult homeless population, the adult single homeless population in these communities, and we begin to develop relationships with our local hospitals, with our local primary cares, with our EMS and fire departments, Albany, with our county mental healths and local shelter systems. Through that, those individuals that are your highest cost are touching on all the services. So when you start to develop the relationships, you start to very easily identify like those that are most in need of service. And when you start to implement like a very client-centered a very client-centered, like evidence-based strategies like housing first, right? Just put somebody in an apartment and worry about the treatment, the sobriety, worry about anything else after we meet the housing need. So we started to see costs decrease, and that program was extended for 2 more years, which ends this upcoming year, 2018. And then the MRT program is no longer a pilot program and has now extended for like up to 5 years, and we'll keep resubmitting. We serve about 30 individuals in over Albany and Rensselaer County for that program. So it gets in a little bit. I'll talk about our outreach and engagement with both of our programs, Project Host and Project Connect, and I'll talk a little bit more, we'll get a little more specific about the relationships that we formed in the community and how those relationships have contributed to serving a really challenging to connect with, a really high cost Medicaid, you know, an overutilizing of emergency services population. Like I said, I want to stress the evidence-based practices that we use. Our case management model is called critical time intervention. It was adapted from, I think, New York City, where it was implemented to serve individuals who are chronically homeless and struggling with mental illness or substance abuse. It's a time-limited case management model aimed to reintegrate an individual back into the community. So it allows our case managers to really focus on that critical time transition from homelessness into housing and look to reconnect a person into the community and into the supports that are already there. And then as we start to test out those supports and as we start to phase an individual out of our case management, it opens up our resources to the next individual who might be, you know, high vulnerable on the street, overutilizing services. Supported employment, you know, the idea that every person can get a job, and those are like small victories as far as like making a resume and applying for a job and things like that. We utilize harm reduction. SOAR is quick access for individuals who are homeless to Social Security disability income, and you know, utilizing housing first and motivational interviewing. And really, you know, there's different levels of a housing first model, and you know, all communities are now per HUD implementing like a housing first model, but really implementing like a housing first heavy model, like doing whatever you need to be done, whatever needs to be done to get an individual in housing. And this has many different facets to it. A big one is landlord engagement in the community. So developing relationships with landlords in the community and really focusing on those relationships, because the reality is like some of these housing outcomes are not going to go so well. And so what are you doing to nurture that relationship with the landlords in your community? What are you doing to make sure, like within your budget, to make sure that these relationships are continuing, that not just a landlord relationship gets ruined because of one bad outcome in a housing placement. And really, I mean, some of these individuals, getting them into housing, it takes a lot of resources, a lot of case management resources, and so doing what needs to be done to get people out of the ER and into housing. So that gets in a little bit to the relationships that are developed with hospitals, with health homes, with emergency rooms, and with local shelters. We really we look for like a really prompt response, especially from hospitals, but from all community hospitals, police departments, but from all community providers. The thing about emergency rooms is like people are there and then they turn around and are quick out. And with social workers, they're busy in the hospitals. So it was really like, it was this relationship that you couldn't just like, you couldn't force it. It was this relationship that had to materialize kind of organically. And they had to see that like these people are willing to come into our emergency rooms and serve some more difficult. And then there had to be outcomes associated with it. So there had to be like a decrease in cost. Like they had to be like, where did this person go? We don't see them anymore. And at times it was, you know, they're now in an apartment and they're being served, and not necessarily that they don't come anymore at all, but their costs, their visits to emergency rooms have dramatically decreased. So now, I mean, these places like social workers in the hospitals, inpatient units, and in ERs are contacting us, right? We have this high cost user, they're here all the time, they're homeless, can you help? And, you know, our police departments, you know, I just was reached out to by a local lieutenant saying, there's been this many number of calls at these 3 locations in our areas over the last month, can you do some outreach there? This many number of calls due to homelessness. And so I think that it's just a really, it's just a really cool service that it's a really cool collaboration that we've developed within our community to be able to identify those that are most in need and start with them and go from there. So it gets in a little bit to our contracting with managed care. So in serving individuals, right, from a housing perspective, there needed to be like a tie-in with healthcare because the integration of housing and healthcare. And as housing case managers, you know, you want to be clear in roles. You want to be able to focus on your landlord relationships, on the tenancy needs, on the requirements of any tenant. And as a health home program, we're partnering with health home care coordinators. And so through this learning process and engaging with health home, we're realizing like what can and can't be done or what needs to be done for an individual in order to have successful health outcomes. So another thing we started to realize was that people in our program have managed care, and particular managed care agencies, managed care organizations have social workers and case managers that will come out into the community that are either implanted in, you know, our drop-in centers or our shelters in the community or hotspots, primary care hotspots. Or you can refer, and they have social workers that will come out into the community. So again, like naturally this relationship formed. Hey, we got this person in an apartment, but they're needing connection to primary care. They're needing connection to a specialty doctor or whatever it might be. So we started to work with local managed care organizations, and we were able to use like our map systems to identify what managed care organization each individual was with, get a quick release, and just reached out directly to the managed care organizations. So that's how our relationship was built. Quickly, I mean, we're having weekly or monthly case conferences on some of the higher need clients that maybe aren't improving, that are already in housing, to say like, what are our next steps for this person? What is something that we haven't tried? Should we keep trying the things that are or are not working? So a relationship was formed naturally with local managed care organizations. And I think like, and I know like I've talked about this a little bit, but the relationship was built off the proof that our housing programs were providing quality services to like to the managed care organization's highest need. So it's like you, as a managed care organization, can look at the numbers and, you know, you tell me, we'll tell you who we're serving, and we also have health outcomes. So we can see, like, track the costs, right? Because they can do it. Like, I can't necessarily track costs, but as somebody who has relationships with our hospitals, like, costs might be going down. And we believed in what we were doing, and we believed we were seeing outcomes. And so that's how the relationship was built. And then when value-based payment came on board and people are talking about contracting with, I just want to apologize if I don't get all this verbiage right. This isn't really my forte, but so value-based payment, and people are talking about contracting with CBOs. So it was a natural, like a natural conversation for us to go to the MCO and for our executives to go to theirs and say, you know, how are we going to form a contract, and what are you guys looking for in order to contract with the CBO? And, you know, here's what we do. DOH had provided some feedback for us as far as the cost benefit and the decrease in visits to that point. And so now the managed care organization we can, you know, get releases, send them SIN numbers with a client number, and they can look at the outcomes themselves. And so a conversation was started. The trust and quality care had already been established. So some of the barriers and mitigation, obviously just the financial piece, like caseloads, how many clients are you looking to serve? How are you looking to serve them? In what capacity? For us, like our model of business didn't really need to change because we believe that it has been and is being proven. We're using evidence-based practices, right? Like, so strategies that have already been proven to be effective. We're providing agency-based, like, quality assurance to those practices to make sure we're implementing them correctly. And so our model of business was already really clear to them. So the financial piece, you know, what are they looking for? How many case managers? How many clients are you looking to serve? What's that caseload look like? are apartment subsidies needed? What do those rental subsidies look like? And so from there, I mean, it's just working out negotiations financially and establishing that level of service that they were expecting. So right now, we don't have a contract. We're in the final talks of contracting with local managed care organizations. We believe that it will be implemented soon, and we want to continue to market ourselves to other managed care organizations in the community and to other MCOs and PPSs, because there's like a level of service that's provided by our CBO that can't necessarily be provided by an MCO, right? We're willing to do things in the community. We provide a level of service that to a population that is high cost to MCOs that they can't necessarily provide. And so we can market ourselves in that way, and we're looking to continue to do that to additional MCOs and PPSs, which there's conversations with our local PPSs in Albany as well. I'm going to talk a little bit about social determinants of health and how we make an impact on social determinants of health within our clients and our health and healthcare social determinant. Already talked about partnering with hospitals, with managed care organizations. Another service that we have in Albany is a Program Services Coordinating Committee. It is a committee in Albany County held at Albany County Department of Mental Health for high utilizers. So it can be referred from local hospitals, social workers, Albany Police, Albany Fire, and all of these individuals, as well as mental health and shelter providers, ACT teams and AOTs, everyone sits at the table, right? And so you identify your highest cost utilizers in the community, those that are touching multiple services, and people can't figure out how to serve them. So once a month, this committee meets and talks about how to creatively serve individuals. There's been a lot of people who we've been able to move through that list, to get them off the list, but it's a place to go to find support for people who are overutilizing services that one person as an individual can't necessarily figure out how to serve. Like I said, we provide 29 rental subsidies over Albany and Rensselaer County just in Project Host. Offer SOAR and supported employment. One thing that we do with our clients in order to engage them back in the community is we have like focus groups, and we try to hold multiple events a year that are very client-centered. So we put on a Thanksgiving that's very intimate for our clients, a coat drive. We've had a breakfast with Albany Medical Center, so our local hospital, where Albany Med wanted to come and ask our clients questions about their own healthcare. So we were able to engage our clients in a breakfast, and Albany Med was able to ask them questions about what's working and what's not working for them. And again, these are some of the highest cost users in their hospital. And so to be able to not only give a hospital direct feedback from clients, but to give clients a voice and for them to feel heard, I think has been it's not only how we try to implement our services in our program, but to actually go out into the community, into other providers, and to let them have a voice, I think has been really impactful. I talked a little bit about Albany PD and the local fire department in Albany. I will say that it's very ahead of the curve how our how our first responders and our emergency response in our community is getting on board. We have a LEAD program in our community, a diversion program that identifies low offenders that are mostly offending due to drug-related offenses, not drug-related offenses, but offenses that can relate to drug activity. They refer directly to us, and we can collaborate with their case managers on how to provide housing while they provide a case management to divert a person from the criminal justice system. And we talked a little bit about our outcomes, and these were outcomes that were sent to us by Department of Health in the fall. And that's all I got.